So we're going to move on in our junctional rhythms, and we're going to talk about the junctional escape rhythm, or the junctional rhythm. And in this section, we're going to especially focus on how the AV nodal area functions as an escape pacemaker for the heart. The escape pacemaker can trigger a single escape beat if that's all that's needed, or it can trigger an entire escape rhythm, which essentially it takes over as the pacing for the SA node. So our objectives: identify the origin of a junctional escape complex in the cardiac conduction system, recognize a junctional escape complex on the ECG monitor, understand why the AV node would take over as a primary pacemaker for the heart, and identify the rate parameters of a junctional rhythm. So the first thing we're going to talk about are actual junctional escape complexes. So the identification of a junctional escape complex is very similar to identifying a premature junctional contraction, but instead of it being earlier than expected, it's going to be a late beat. In many cases, the atrial myocardium does not take over pacemaking functions for the SA node when it fails. Therefore, the AV node and the junctional area assume pacemaking responsibility. An AV nodal pacemaker protects the ventricles from standstill, so it keeps the heart moving even if there's failure supraventricularly to it. If an impulse is not received from above, the ventricles are not going to depolarize, at least initially. A junctional escape complex looks exactly like a sinus complex, except it does not have a normal P wave, and most likely it's not going to have a P wave at all. The main difference between PJCs and junctional escape beats when trying to identify them on the monitor is that the junctional escape beats are late beats occurring after the next sinus beat should have happened. Junctional escape beats frequently occur during episodes of sinus arrest or pauses caused by non-conducted PACs. When the AV junction doesn't detect an expected stimulus, it will pick up the slack and fire. So essentially, this is a protective mechanism. This isn't necessarily just an ectopic area. It is a protective mechanism that occurs. So for our junctional escape rhythm itself, we've got to have at least 3 in a row junctional escape complexes. Now, if you think about the intrinsic firing rate of the AV junction, we know that that's between 40 to 60. To have the title of junctional escape rhythm is going to have these junctional escape beats, like you see right here. Junctional escape rhythms, the rate associated with it. So for it to be a junctional escape rhythm, it needs to be a rate of 40 to 60 per minute. We're going to discuss accelerated junctional and junctional tachycardia in the next couple of lectures, but if we see a complex that has an inverted P wave, an absent P wave, or a post-QRS P wave, then it will be considered a junctional complex. And if we see more than 3 of those in a row, especially if we see it looking like it is pacing, then we will call that a junctional escape rhythm or a junctional escape. Sometimes it's called junctional bradycardia because you can have the same rhythm, but the rate will be less than 40, and in that case, we would call it junctional bradycardia. So what are my rules? So the rates, usually around 40 to 60. Of course, we said bradycardia can cause it to be less than 40. It's usually regular. If the isolated junctional escape beat is present, then it's going to be irregular, and we would just call the rhythm a sinus rhythm or whatever rhythm it is, ectopic atrial rhythm with a junctional escape beat. So the P wave is going to either be inverted or absent. It may appear before or after the QRS, and we've talked about the reasons why in previous lectures. And the PR interval should be less than 0.12 if the P wave precedes the QRS, and it's going to be absent if there is no P wave. And if it's a post QRS, we're not going to be able to get a PRI. And then the QRS complexes should all look alike, because once the conduction gets down to the ventricles, they should function normally. So here's an example of a junctional escape. So my rate on here is 50, so that already fits the parameters for the rate. My rhythm, it looks like it is regular. my P wave, we're going to describe this as inverted. And my PRI for this, and we can actually get a PRI, is going to be shortened at 0.12, so right at the cutoff. My QRS looks like it's about 0.08. So with the description that we have for this, we've got an inverted P wave, we've got a rate that's between 40 and 60. This would be considered a junctional escape rhythm. So there's several causes for these rhythms to occur, but it's usually going to be in a situation where the AV node has had to take over as a pacer. So usually it's primary SA node dysfunction, the atria is not able to pick up in pacing, and so the AV node is having to act as an intrinsic pacer. Also, other causes could be increased parasympathetic activity, certain drugs. So we've talked about digoxin. Digoxin is a drug that treats arrhythmias, but it can also cause a lot of arrhythmias when it's outside of its therapeutic dosage or therapeutic range. Beta blockers, when they slow down the SA node especially, and calcium channel blockers too. Myocardial ischemia, sick sinus syndrome, electrolyte disorders, certain neurologic events that affect the central nervous system, or they could just occur idiopathic, though that is fairly rare. So let's look at a couple. So we're looking at this rhythm here. So it looks like you've got a sinus rhythm that's trucking along pretty well, but then you have this long area right here, and then you note that you've got a complex that has an inverted P wave. It's a small P wave, but it is an inverted P wave. So this is actually occurring after your next expected complex, because your next expected complex should occur somewhere around in here. And so your next expected complex is late. So this is going to be a sinus rhythm with a junctional escape beat. Now, if this beat was earlier, so if it was right after the T, or right on the T, then it would be a PJC. But in this case, it is a junctional escape because it is occurring later. Now, this rhythm here is pretty unique because we haven't really talked about the ectopic atrial rhythms. But one of the things that I note about this is that it is a rate of about 60, and I've got an inverted P wave, but my PRI is pretty regular. But then I see my junctional complex, and it's occurring real late. So this actually would be an ectopic atrial rhythm with a junctional escape complex. Now, if you were to call this a junctional escape rhythm, I would still say that that's okay, simply because it is a little hard to tell the difference between the two. So you could call it a junctional escape rhythm with a junctional escape complex, but that is kind of redundant there. So this one, we've got what looks like a pretty strong sinus rhythm underlying, but then we've got a late occurring complex here. No P wave, it's most likely hidden. It's not after the QRS, so we're looking at a sinus rhythm with a junctional escape complex. Again, it's occurring late. This one actually, you've got a really long period, and then you've got this beat right here that if it were to pick up, just like these complexes here, if it were to pick back up, we could say that this is a junctional escape. But what's actually happening here is that you've got a junctional escape complex, not a junctional escape rhythm, that's occurring because you've got a period of sinus arrest, and now the junctional escape complex, the junctional area is like, oh no, we've got to pace. So it's picking up pacing. So if you were to run a continuous strip, what you would probably see at this point is a junctional escape rhythm. So this is a sinus rhythm that has a period of sinus arrest and then is converted into a junctional escape rhythm by a junctional escape complex. All right, so our fifth rhythm here, let's do a rhythm analysis of it really quickly. So our rate is 50. Our regularity is regular. our P wave. This may or may not be a pseudo S wave or a P wave that is hooked into the S wave. So it may or may not be an inverted P wave that's post QRS. My PRI is non-existent, and my QRS looks to be about 0.06. So I don't have an identifiable P wave, and my rate is 50, and it's a regular rhythm. So this is just going to be a junctional rhythm or a junctional escape rhythm. So the same thing with this rhythm right here. My rate is 40. It's regular, so the AV node is pacing. The blue arrow is pointing to the same thing that we had looked at just previously. This is very possibly a retrograde conducted P wave post QRS, which would indicate a junctional rhythm. But I don't have a PRI, and then my QRS looks to be about 0.10 or so. So just following my rules, I've got a rate of 40. I don't have a P wave, or either I've got a retrograde conducted P wave post QRS. This is going to be a junctional rhythm or a junctional escape rhythm. Looking at this, don't get this confused with a fibrillating baseline of atrial fibrillation, because if I check my regularity, it is regular, and it's not irregularly irregular. My rate is 50. It's regular. I don't have a P wave present. My PRI is absent. And then my QRS, measuring from about right here to about right there, is about 0.06. So again, following the rules, the parameters of the rhythm, this is a junctional rhythm or junctional escape rhythm. So in this one, the blue arrow is pointing toward a positive wave immediately after the T wave. This, in fact, is not a P wave at all. It's actually a U wave. U wave has no special clinical significance in the evaluation of this arrhythmia, except it could raise a possibility of some type of pathologic process, but that's not our purpose at this moment. So we're trying to identify this rhythm. So my rate is 50. It's regular. My P wave is absent. My PRI is absent. And then my QRS looks to be, so measuring from right here to about right there, so it looks to be about 0.10 or so. So again, this is a junctional rhythm or a junctional escape rhythm.